All right. Good morning, everyone, and welcome to the November 16th PEBB board meeting. And I'm going to go ahead and do roll call, and we'll see who's in attendance. I'm Kimberly Hendricks, the chair. Kate Nass.
Good morning, I'm here.
Good morning, Kate. And Kim Harmon.
Yes, good morning.
Good morning. Sean Parkman.
Good morning.
Mark Perlman. Good morning.
I'm here and my cat is too.
I see that. You've got a welcome observer. Saban Martin.
I'm here. Good morning.
Good morning. Jeremy Vandehey.
Jeremy will likely be a little bit late.
Okay.
Legislative days today.
Oh, okay. So does that mean Senator Betsy Johnson or Representative Andrea Salinas? Are you with us today? Okay. Okay, well, we'll go ahead and open up the meeting. And our first action item is for the approval of the September 21st meeting minutes.
So, Kimberly, this is Siobhan. I'll make a motion that we approve both the September and the October 2021 minutes.
Okay, so we have a motion to approve September 21st and October 19th minutes. Do I have a second?
I'll second. This is Kim.
Oh, thank you, Kim. Any questions? Okay, I'm going to go ahead and do a roll call vote. Kimberly, aye. Kate Nass.
Yes.
Thank you. Kim, second. Aye. Sean Parkman.
Approve.
Thank you. Mark Perlman.
Yes.
Thank you. Siobhan, the first.
Yes.
Thank you. And Jeremy, have you joined us yet? Okay, so it looks like the minutes are approved as written. And now we will go on to the meat of the meeting. How exciting. I'm sorry I missed the October portion of this. And who's going to kick this off for me? So it looks like we have Brian is going to kick this off for me and introduce a few folks. Good morning, Brian.
Thank you. So members of the board, I'm Brian Olson. I am your contracts team lead. I'm here today, though, as one of your staff members who support your PEBB member advisory committee. I am back today with our partner, Stephen Nelner from Mercer Health and Benefits, and we're going to present the rest of PMAC's HEM recommendation today. And why don't you, Stephen, go ahead and introduce yourself to the group.
Sure. Thank you, Brian. I'm Stephen Neldner. I work in Mercer's Total Health Management Specialty Practice. And in that practice, my role is to work with organizations on developing strategies around health and well-being, vendor selections, vendor monitoring, measurement and evaluation of program impact, and lots of things in between. Some of those things in between include, I also work for, I shouldn't say work for, I do work for, but it's an informal role to the HERO, the Health Enhancement Research Organization. Mercer has a collaboration around the HERO Health and Wellbeing Best Practices Scorecard in collaboration with Mercer, which is an inventory of best practices. I'm a co-author of that HERO scorecard. I also serve as HERO's chair of the research committee. So that's been my role, and that's why I'm giving you that information, because my role with PMAC in the last couple of years is to help provide support for identifying evidence-based best practices. So that's my background. I have done research and have a number of published papers and research chapters, or excuse me, book chapters that relate to best practices in health and well-being. And as I said, I'm committed to delivering those for our clients of Mercer's. And I am very happy to have been working with a great group of people in the PMAC for the last couple of years who have been so committed to this. And they've been intellectually curious. They wanted to know the why, and they wanted to be very clear about putting forth the best recommendation for the future of the HEM program. So I'm grateful for that opportunity and grateful to be here today.
Thank you, Stephen. And let me just say for the board too, Mercer's provided a ton of leadership on this project. As you know, PMAC is not comprised of necessarily daily healthcare professionals. They're state employees, a lot like us, who may or may not work in the healthcare arena and only meet 10 to 12 times a year. So with Mercer's leadership and specifically Stephen's leadership, we've been able to get up to speed on what the evidence says and have some pretty robust discussions about what this program could look like going forward. And at last month's meeting, we were able to tee up the assignment that led to this recommendation, even though we weren't able to get to the rest of the presentation. In summary, just to remind y'all, the assignment itself, the board asked PMAC to describe what the future HEM program could look like if we followed the evidence, considered what other large employers are doing in this space, and took into account our own membership's preferences. Today's discussion, at least the substantive part of the discussion, will really begin with Stephen presenting what the evidence says about these types of programs, including addressing some specific questions that were posed by the board leadership team early on in this assignment a couple of years ago. Stephen will then, after presenting the evidence, present what PMAC's actual vision is for the future HEM program and how it could be structured. I will then talk a little bit about some of the challenges associated with implementing this type of program and some of the operational hurdles we would face with moving this forward. And then last, I'll talk a little bit about what other recent work PMAC has been focused on, partnering with folks like Uplift Oregon and the Worksite Wellness Coordinating Council, which will lead into a series of questions where I'm going to ask you guys to take action. I mentioned last month this isn't going to be a traditional recommendation where we ask you just to approve and implement a very specific program, but rather, after sharing some of PMAC's recent work and focus areas, I'm going to ask the board to provide feedback on what are some of the short-term projects or focus areas that the board would like to see PMAC focus on going forward now that this HEM assignment is at least completed at this phase. And then we'll also ask the board to essentially endorse or confirm this vision for HEM that Stephen is going to lay out that PMAC came up with. So again, not necessarily asking you to approve specific components, but more to endorse a vision of what PMAC has painted. And then we'll talk about getting feedback from you guys on next steps and how you want staff and PMAC to work together to move all of that stuff forward. So with all that said, that was quite the mouthful. Before I turn it over to Stephen, are there any questions about what we're hoping to accomplish today? Okay, and so Rose, I think we will want to skip ahead a few slides to the second part 2 of 5 in the presentations. And just keep clicking and then. Well, there we go. Okay, back one slide, and then we can hand it over to Stephen. And then Rose, if it's okay, Stephen and I will just prompt you to move the slide deck along as we present. Last, let me also just recommend to the board members and to staff, please speak up and ask questions during these presentations. We want your feedback. If you're not understanding what we're trying to communicate, please speak up, ask questions, share comments. We're really looking forward to have as much of a discussion as possible and get as much feedback from you guys as possible to the extent you have feedback. So with that said, Stephen, I'll turn it over to you.
Thank you, Brian. All right, so the first part of the presentation is to go through some of the evidence and the evidence that we know from the research literature supports best practices in health and well-being. And then we'll address specifically some of the board's original questions about the existing HEM and other things that relate to a future HEM. But we'll start first of all with some study data that one of your carrier partners provided. If you'll advance to the next slide, please. And you can see that Dr. Wright from Providence presented this report to the PEBB in 2019. And essentially what Dr. Wright did and Providence did was look at data and utilization data from your population that's enrolled in your health plans and tried to see if there were differences between those who participated in HEM and those who did not. And you can see that that analysis also included a member survey. So the survey results, when participants were able to maintain lifestyle changes, they noted significant improvements in their lifestyle, and there were also improvements in outcomes measures around diet, exercise, and weight. The claims analysis results show that HEM participants had $38 per month lower total healthcare costs, and different costs were attributable mainly to reduced inpatient visits, and they were concentrated primarily on older, sicker members who already had high healthcare costs, and we would characterize that as those people who have the most opportunity to improve their health and lower their costs. Those are the ones where we saw that reduction. And you can see the note here that there's the possibility of redoing this study with Providence in the future. You can see that we have a box here with Mercer's comments about this. So just want to raise some caution around how you interpret this. This is not a cause and effect study. People weren't randomly assigned to participant and non-participant. It was just people who participated and didn't choose to participate. So there can be some bias. But the other factor to keep in mind is that you had over 90% of your population participate in HEM. So there wasn't much of a comparative group. And an equally plausible explanation beyond participation in HEM could be that people who didn't participate in HEM just weren't that interested in their health. Now, we don't know that for sure, but that's an alternative perspective on why they had higher healthcare costs. So just want to caution that this was not cause and effect. That's not to say there wasn't value in HEM, but as you'll see as we talk about the evidence and the opportunity for improvements in best practices, we think that there is certainly more opportunity for healthcare cost savings and health improvement going forward into the future. Any comments or questions about that data? Okay, so let's move on and start to look at what the evidence says. So there are going to be some key themes here that you'll notice in the research evidence that we present. And one is presented in this, and that is the more people are involved, the more people are engaged in doing something, taking action on their health, and particularly on the healthy lifestyle, such as better eating, more movement, managing stress. Those things translate to improvements in physical health. You can see those people who stay participating actively for 10 to 12 months have 30% higher improvement or greater improvement in blood pressure, BMI, which is essentially body weight, non-HDL cholesterol, nutrition, activity. So the more people are engaged, the longer they're engaged, the more improvement we see. And by the way, this is based upon a research study of 52 different unique organizations that were all clients of Red Brick Health. And this research was done in 2015. You'll see that reference on a number of these slides.
And just to point out, Stephen, under the current program, the way it's structured, my guess is most of the engagement in the program occurs during open enrollment when members sign up and take the health assessment. They do agree, that they're going to take 2 health actions, whether they, when they do it at a later time or whether they do it then while it's, at the top of their minds. I'm not sure, but again, engagement is a huge challenge with the current program and how it's designed.
Thanks, Brian. And we can move to the next slide, please. So is there one slide before this, perhaps? No, okay. Now let's go back to 6. It's the slide after it. So I'll talk about the best practices first, and then we'll look at how those play out. So here's a list of best practices that we know from the evidence, from research evidence, are important to achieving best outcomes. And again, I'll define best outcomes as improvement in health risks, improvement in actual physical and mental health, lower healthcare costs. And the other one that we know is an outcome that we just identified in research that I was part of and we published last year on data from the HERO scorecard. I referenced that earlier, the Health Enhancement Research Organization's best practices in health and well-being. We have a database with nearly 2,000 different organizations in it. And the other outcomes measure that we found was associated with best practices was employees' belief that their organization supports them in their health and well-being. So that's a pretty important outcome as well, right? So this other theme, I mentioned more engagement equals better results. The other thing is more best practices that are in place by the organization that's sponsoring the health and well-being initiative, the more likely you'll have better outcomes. So best practices are important. Some of those are give people choices. Let me choose what I want to do. Let me choose how I want to engage in it and when I want to engage in it. And as much as this experience can be personalized to me, the better it will be for me to engage, the more likely that I will stay engaged. If we talk about rewards, and that's what the HEM program is about, right? It is providing incentives. We know that external rewards like cash incentives are important to get people to take initial action. But ultimately, over time, we hope that people find enough value in the experiences that they've had and the improvements that they've achieved personally, that they will continue to do these activities over the course of time, and they'll become habitual. It won't be something that you even think about. It's just who I am. It's what I do. And so that's the one thing, starting out with extrinsic motivators to get people engaged, and then hopefully a rich experience, meaningful experience throughout the course of interacting with the well-being services and programs. Then how do those rewards get structured? Ideally, you give people rewards as closely timed to when they actually complete the activities as you can. That's not always possible or practical, but again, the more frequent, the more closely they're related to when people actually do the activities, the better. The evidence suggests that it's best to reward for engagement, not outcomes. There was a phase in time a number of years ago when many organizations said, well, let's just reward for achieving biometric results. Having blood pressure, cholesterol, weight, BMI, all those in range. And the theory was, well, if we focus on that, then people will do whatever they have to do to get there, right? Well, people generally don't do that on their own. They need more support, and the focus really should be on engaging in things that support them and taking the actions that will ultimately lead to those changes in health and health improvement.
Steve, it looks like Rose got kicked out. She had a technical issue, so
Okay.
I can just make a comment while she's logging back in. You know, it seemed like initially when the health engagement model was rolled out, there was really a lot of resistance for various reasons around confidentiality of their data and other just change factors that made people resistant. But over the years, it seemed like, you know, we would get about 70% participation initially, and then slowly crept up to 80%, and then 85%, and then even pushing 90%. But just getting past that 90% participation mark has not happened. There's just about 10%. I'd say probably closer to 5 to 7% that are just not going to do it every year, and then the rest, you know,
And Ollie, I would say that, I mean, while we want 100% engagement, you know, that last 10% may not be a battle worth fighting if those are just the percentage of our population who are going to refuse to engage. And in fact, just to prep the board, I think the requirements for him have been pretty light compared to the incentive. And so if we move towards a model where more is going to be asked of members for maybe a more robust incentive, I could see us implementing a more robust program that actually has slightly lower participation, but the participation it does have is a lot more engaging and a lot more successful. So just some food for thought. Yeah,
very true.
Yeah, that's a really good point, Brian, and Ali as well. I think, yeah, 90+% is extraordinary. Very few organizations achieve that. But I think Brian's point is really important to keep in mind as we move to a more robust set of requirements to participate and get incentives, is that I would encourage you not to be discouraged if the participation rate goes down, because just for the point that Brian made is that the definition of engagement is going to change. You know, before, if it's just checking the box and saying, I'm going to do something, but no evidence that anybody does that, versus now you're going to have some verified actions and they're going to be meaningful actions that are likely to lead to a health improvement, then it's a little bit higher bar for people to achieve. And that doesn't mean that we still won't get high numbers of participation relative to what it could be, but it probably won't be 90% in the first year. It might be lower than that.
And Ollie, do you want me to, I think I can pull up the presentation and share it on my end. Does that make sense?
Brian, I'm back on. Sorry,
okay,
yeah, I got kicked off. I think it was Teams. They kept trying to reconnect me. So,
but you're on the team. We can't have it kicking you off, Rose.
I know.
You're a vital part of this operation.
Hey, one of the things I just want to jump in on, and I'm hoping we'll spend some more time on this, is that portion of the best practices around how, if there's high engagement among supervisors, management, leadership, you know, a structure that supports the wellness, that can increase participation by 25%. So, I mean, that's just a piece that I think we should have more conversations on as a board, because I would like to know more about like what the agencies are doing to support the wellness work in each of the agencies. And if we as a board need to be making a recommendation around FTE in different agencies to support the wellness work, since we don't control the budget authority. But, you know, how does that intersect with this? And I know, you know, Teresa leads that work. So just wanted to name that.
Yeah, and Siobhan, I think that could be a great thing to pick back up later on in the discussion when we talk about some of the questions I'll ask the board, not only have to do with PMAC's work, but also the coordinating council, because Teresa and I work fairly closely and there's some overlap between the committees. And so it is also fair for the board when you get to that point in the discussion to say, you know, we think that, you know, PMAC and the coordinating council could maybe coordinate in some manner in this future HEM program, where we can lean on the coordinating council to help drive engagement with, you know, the management, the supervisors, and the workplace environment, while maybe PMAC does some other pieces of the analysis, like recommending, you know, certain vendor requirements that we would contract with. But I don't want to sidetrack us. I'll really get us off on a tangent. So I will mute myself and hand it back over to Stephen before I get in trouble.
No, thanks, Brian. That's all good conversation and plays into the overall discussion. And Rose, if you wouldn't mind.
I'm so sorry. This is Kate Nass. And Siobhan, I think that's a really good point. And I think our timing right now is the right timing for agencies if they need to put requests in for the budgets. This is the time that we should help inform them. So I think that's a good flag. I just want to pipe in because it is the budget process and it feels really early, but we are at a spot that agencies need to figure out what they're asking for. They don't have it in their current budget.
Great.
Sorry, Stephen, please.
No,
I didn't want to sidetrack later on.
No, that's perfect. And please interrupt and interact. It's your session. We want this to be for your benefit. So however we can do that, we will do that. And Rose, if you don't mind advancing to slide 6, we're going to continue the discussion about best practices, please. So yes, so the rewards, to pick up on there, we're talking about The last point was reward for engagement, and engagement is important. As we saw, the more engagement, the longer people are involved, the more likely they are to achieve their goals. We recommend spreading the incentives out over a variety of activities, so not just for gateway activities, so not just for completing a health assessment or biometric screening, but actually for doing things throughout the course of the year. Communication is so vitally important. People need to know how to access what's in it for them, how to access it, how easy it is to do, and be reminded, because it's great to have, I'll use the example of themes, a monthly theme or a quarterly theme or a lunch and learn. You know, that's only as good as far as it resonates with people on that particular day or that particular month. If I'm not thinking about heart disease today, but next month I have a parent that has a heart episode, I might be more interested in preventing heart disease next month. So the idea is that we want to communicate regularly through a variety of modes of communication and media, and as much as we can, find ways to target and personalize the messages. I mean, to a large part, that can be accomplished through the centralized well-being vendor platform, but you also have other means of communication that we're talking about now with your various stakeholder groups, the Worksite Wellness Coordinating Council and PMAC and others. So, but communication is vitally important. Without that, nobody knows that there are actually programs and services and how to get engaged. So while I put the healthy culture in that lower right quadrant, that's not, you shouldn't take any significance of that it's less important. I should have probably put it in the upper right, I should have said, because if you have it on a matrix, it's the highest reward and sometimes the highest effort as well, if you're looking at it from a level of effort grid. But the idea is that culture means everything. Cultural support. That means that it's more than just making a statement, and the governor's already made a statement, and I know that's a very sincere statement, but now other stakeholders, other leaders, and also mid-level managers and frontline supervisors, and then grassroots champions all need to be moving in the same direction and supporting each other. The example that we often use is that if there is a frontline supervisor who's productivity oriented, we got to get the job done, we've got to do this, and that supervisor views thinking about well-being, participating in well-being as an impediment to productivity, as opposed to an enabler of productivity, not likely that that work group is going to feel supported in taking action on their health and well-being, at least not in the workplace. So, but on the other hand, if managers, supervisors, leaders in the organization recognize that indeed people who are at the highest levels of health and well-being are the most productive, they're most engaged, they're thriving in their lives at work and at home. Those people are the ones that are going to move the organization along to higher levels. And that can be accomplished best when the whole organization recognizes that and supports it. And then at the grassroots level, wellness champions. Everyday employees who just are, and they're not necessarily the super athletes or the super achievers, but they're interested in doing something more with their health and well-being, and they can be supporting others as well. And you can see that a clear part of that is support for health equity and social determinants of health. Really, I mentioned this on an earlier call today. The research literature shows that people who are most marginalized, people who are suffering from scarcity of some kind, like financial scarcity, scarcity of time because they're giving care to their family, an extended family. They have less access to quality health care, less access to good quality food. Those people are the least likely to participate in health and well-being initiatives. And they probably need it the most because we know they also have the highest health risks and they also have the highest percentage of chronic conditions. So the whole point of culture and support is to help find ways to support people in breaking down the barriers of personal and social determinants of health or health inequity and other kinds of inequity to better be able to participate in their health and well-being. Any thoughts or comments on these best practices? If not, let's move to some more evidence. On the next slide. So these are those 52 companies that I used in the earlier slide that were used in the Health Brick research study of 2015, and each one is plotted, and they've been broken down into 3 sections. Far left used the least number of the 14 best practices that were tracked by this organization. On the far right, that group of organizations used the most best practices. And if you look at the colored bars, you can see that sustaining activity for the most months of the year is represented in purple. The bright green is 4 to 9 months of engagement, and the light participation is the darker green. So the idea would be the most sustained engagement, right? We showed that on the earlier slide. So the more best practices you're going to have in place, the more purple bars you're seeing, the height of the purple bars in that top third of organizations that use most best practices. So again, the 2 emerging themes that you're seeing from the evidence are more best practices leads to longer engagement and better outcomes. I guess that's 3 themes, better outcomes. And let's move on to the next slide, please. So we're moving now to the questions that the board asked about the evidence. So one of the questions that was asked of the board, what is the evidence on intrinsic, that is internal versus extrinsic motivation? And you heard me say earlier that ideally we think there's a combination of the 2. I'll elaborate a bit on that in the next slide. But starting out with some, and this is almost like your college psychology class, right? So you can see that we're using some terms and even the sources of the self-determination theory and the organismic integration theory, all big words, but I think we can break it down just by looking at this from a common sense perspective. We start on the left side of the continuum with somebody that has no motivation at all, and on the far right, we move to somebody who is highly motivated internally. And what are their regulatory styles? What goes on in their thinking that leads them to have those different levels of motivation? Well, those who have little or no motivation, the things that get them to do something are externally motivated. They're motivated by getting a reward or trying to avoid a punishment. Moving a little bit higher up the continuum, the interjected regulatory style says behaviors performed to avoid guilt or shame. So, this is sort of the group shaming and not wanting to be part of the group, but if I don't do this, I won't be part of the group. So a little bit more motivation, but it's externally oriented. And then we move over to the side of the continuum where the motivation becomes more internal. Somebody says, if I'm using my identified regulatory style, I accept the behavior as it's being important. So this is somebody who's probably making a good faith New Year's resolution, saying, I'm going to be more active, I'm going to eat better this year. So I know it's important that I do that. And then we move to the highest level of intrinsic motivation. And this is behavioral that's fully aligned with my personal goals, my values, my purpose in life. It is who I am. I am someone who takes care of myself, and I do that by moving more, eating better, managing my stress, having good personal interactions with people, getting the best quality health care when I can, having consideration and compassion for others. All of those things come from me within. So the goal, and if we can move to the next slide, please, is that, as I said earlier, if we can help people initially engage by providing some external reward, and that's where the financial incentives come into play. Prizes, money, premium discounts, HSA contributions are all examples of that. But ultimately, through their participation in meaningful to them, wellness and health services, I have fun, I accomplish something that I never thought I could accomplish, I'm helping others, I improve my health. I feel fulfilled because I actually achieved the goal. And my purpose in life is even more clear now because I know that if I align what I want to do at home and at work, and I combine that with a better state of health and well-being, I can do anything. That really becomes very motivating from the inside. And that's ultimately where we want to go for the majority of the population. So I'll stop on the motivation and that question about intrinsic and extrinsic motivation and see if there's any follow-up questioning from the board.
Stephen. This is Siobhan. I just had a question, not around the external versus internal, but if there is an analysis of where we are on the continuum. You know, the previous slide that you showed, showing what different employers do, if that analysis was done.
I think I'll probably refer to the slide I'm going to get to a summary slide where I provide reactions to perceptions of the current HEM model relative to best practices, if that's okay. And if I don't cover it there, then ask me some more questions and we'll get there. All right?
Sounds good.
Is that fair? Okay, next slide, please. So we also looked, as a part of the HEM project, at incentives from what's out there. So this will not answer your question completely, but starts to get at what's going on, and we'll connect it to what the HEM looks like and might look like in a few more slides down the line. But we looked at 4 incentive models. I brought to the PMAC examples of real-world client incentive models. And they were a combination of different approaches. You can see that in summary, one model offered, and we're going to go through these at the beginning of the next presentation, so I won't spend much detailed time here. I'll just leave it at the high level that they were generally focused on giving dollars for some specific actions. There were sometimes dollars rewarded for completing multiple actions. And then models like the one you'll see at the bottom of this slide that by achieving certain point levels from doing a variety of activities, points associated with given actions and activities, that you could reach a threshold of points and then earn some kind of cash or credit for the incentive for achieving that level. And there were 2 models like this that we talked about. We talked about an annual model where there were up to 4 levels throughout the course of the year with different point thresholds to achieve, points being cumulative from one level to the other, that were associated with additional accumulating cash rewards. And then there was also a model that incorporated up to 4 levels within each quarter of the year. So points for each of 4 levels within a quarter, then points reset to 0 at the beginning of the next quarter, and you were in 4 levels of again, and so on throughout the 4 quarters of a year. The PMAC decided that, at least as a starting point for the next iteration of HEM, that this model that looked at levels throughout the course of a year were probably the right way to start and would be the most appealing and achievable in the short run. And this model offers the advantage of there are a wide variety of activities that are available, and we're going to go through specific examples in the next portion of the presentation. Excuse me. And by encouraging members to participate to achieve different levels throughout the course of a year, you're drawing them through the course of the year and keeping them continuously engaged if they want to continue to earn the incentives. And the other component of this is that their well-being platform, their vendors that have on their platform a marketplace where while you earn these points and the cash equivalent, once you achieve the threshold, you could automatically go to that marketplace and redeem them for a gift card or merchandise, or make a charitable contribution, a variety of things that you can have in that marketplace. So one-stop shopping, you earn the points immediately for the things that you do, you achieve a threshold after you've accumulated enough points, and you can go and fulfill it, or you can let it ride for longer to buy a bigger merchandise down the line, or a bigger contribution. One of the limitations of this model, and quite frankly, almost any model, is tracking activities that might be outside of the wellness platform. So if there are worksite initiatives across the state, they still could be uploaded onto the platform, but a little bit more administrative burden, just as a point of consideration.
Yeah, and this is important, I think, for the board to know, in that PMAC envisions kind of the level of data or information accessible to PEBB staff being similar going forward. So what you'll see in the next presentation is when we paint a picture of what this future HEM program could look like, it contemplates having a wellness vendor. So that way, again, PEB staff would not have to confirm or audit any sort of program requirements or activities, but rather would be done so through the wellness vendor, who then may or may not interface with our various carriers.
Thank you, Brian. And are there any questions or comments from anyone on the board? And if not, we'll move on to the next slide, please. So drilling into additional questions from the board, does the evidence suggest whether we should provide a specific and limited list of applicable health actions? And while we said earlier, it's important to give participants choice on the what, the how, and the when, and you want to provide enough variety that can appeal to the needs and desires of the majority of your population, there is a limit. Too many choices can lead to indecision and inaction. So just to have a wide open, and frankly, this sort of speaks to where the HEM is today, is that, you know, choose whatever you want to do and say you'll do a couple of things, but there isn't really a curated list of things that people should focus on. So that's an opportunity that we see for a future HEM model, and you'll see how we've played that out in the examples in the next presentation. So yes, a list and choice, but within reasonable limits is the specific answer to this question. And the next slide, please. Does any evidence speak to this or similar programs' relative effectiveness for different types of employees? That is, day versus night shift, office versus field. So yes, there is clearly evidence. And again, this is from the Red Brick Health study of 52 different organizations. They sliced and diced the population. This is just an example of some different slices. But clearly, different demographic profiles have different ways that they like to engage in health and well-being. So, and also we want to consider, again, that lens of diversity, equity, and inclusion, and health equity. So ideally, you'll have multiple modalities, multiple ways for people to engage in the activities. Just as examples in the table below, you'll see that coaching is one activity that is often, this is considered lifestyle coaching or condition management coaching. You can see that this particular demographic of females over 50 who work in manufacturing or service industries and are generally lower income or more rural, that those are just the filters that this research company used. They preferred telephonic coaching, speaking with someone on the phone. If you look at another slice of demographics, 25 to 65-year-old females in professional services, middle to upper income in suburban neighborhoods, they were more inclined to use self-service, self-paced. So this might be an interactive program on a website that they can go at their own pace. Still might have quizzes at the end of each section to verify that they've learned something or they took an action to do something, but that's their preferred mode of activity. And then another demographic, under 40-year-old female professionals in upper income or suburban neighborhoods in this particular study preferred to use their Fitbit or Apple Watch or their Google Watch to track their steps and other biometrics and other tracking their sleep and other things, and just put it on autopilot and track it that way. And maybe look at their wrist many times a day, but that was the way they preferred to interact with some guidance on health and well-being. So simple answer is yes, make a variety of modalities available for people to interact in ways that appeal to them. And this is particularly important when, and I've done some focus groups for manufacturing organizations as an example, and talked with the people in the manufacturing site. And they always felt, in this company at least, disenfranchised because they didn't have a mobile phone, they didn't have a computer, they didn't have a company email address. The company had set up some computers, laptops in a break room, but there were only limited things that they could participate in. There was no opportunity for them to do the group things and the real-time things when they were working night shift. So yes, we really do need to keep a broad view of what are the needs of the people. Any thoughts or reactions or other questions about this question? If not, we can move on, please. Does the evidence speak to whether these should be audited, and noting that you currently don't audit? So the simple answer is yes. Auditing or verifying activities is the ideal. That's the best practice. And we've broken it down into what are some of the challenges when you do self-report only versus verifying activities. So when it's self-report only, the question really is, will members do the actions that they say they will? And if they choose activities, are they going to choose meaningful activities, or are they going to prefer the course of least resistance? What's easy to do so I can get credit? And in that model, you're really unable to assess the impact of actions because you don't know what people actually did. And again, the check the box or the meaningful approach are possible, the two alternatives. So you hope that people would do something meaningful, but you don't know. And what if they don't follow through? Are there consequences if you say you're going to do something but you don't? And you don't want managers to be, and you don't want to be police officers to be doing that kind of oversight. And is it equitable for those who did take action that others who didn't take action got the same reward? And probably the most compelling argument is if people aren't doing meaningful things that are likely to improve their health or well-being, then you aren't likely going to have an impact on health and engagement.
And then just another, I'm going to repeat the same comment I made previously, specifically for any members listening, which is it's not PEBB's intent or PEBB staff's intent to be the ones verifying activities. Again, that's why we contract with, the medical plans, dental plans, and we would envision the vendor or other administrator doing those sorts of verifications.
Right. And the advantage of having someone do those verifications is actions are clearly identified, they're measurable, the impact of the outcomes can be assessed, and you can actually use the data from people's actual participation and the outcomes metrics, their health improvement or their lack of improvement, what risk factors are need to be focused on. All that can be used to enhance programs, provide greater focus in what is offered to the membership. And then clearly auditing isn't necessary because you've verified the activity automatically and no questioning about whether somebody did it or not. And no question of equity of people who did or didn't do it. Any comments or questions about this? If not, we can move to the next. Yes.
Just a couple of slides back, just processing all this information. Yeah, I wonder on this one, not to address right now, but just for the purposes of a racial equity analysis, I wonder if anyone has done that. Yeah, consider support for diversity, inclusion, health equity. Like, what is that? What does that look like? As we're thinking about auditing and fairness and all of that, just thinking about that lens.
Yeah, that's a great question, Sean. And indeed, there's a health equity initiative underway right now. A number of your stakeholder groups are working with my colleague Michael Garrett and Aaron Keegan as well on a health equity assessment tool, which is a lens that we're using, or a filtering system that we're using to assess if all of the services or any of the services that you're currently getting from carriers or vendors are addressing diversity, equity, inclusion, and health equity. And we intend, the full intent is that that same set of filters, the health equity lens, will be used to assess any programs you have in place right now and any that you would entertain for the future. So clearly that is embedded, and we're having other discussions on strategy development and refinement that will include that for sure. That will be a primary pillar in everything that's addressed and anything that would be included in future programming. And Teresa or Brian, if you have any other comments about that as well, you're working with Michael and others on that as well.
Yeah, just that with the health equity screening tool, how should I say this without confusing the conversation? PMAC has already adopted that tool as something it will use whenever they're going to make recommendations or proposals to the board. So when we get to the end of these presentations and ask for board feedback and decisions, to the extent the board is interested in moving this type of program forward, you may direct PMAC to do other analysis leading up to that program implementation, and they would automatically, by their own processes, use that health equity tool and look at it through the health equity lens. On top of that, PMAC, I think, even since the retreat where the board just indicated that health equity was going to be a focus or the focused area, I felt PMAC was all ready to pick up that mantle from day one. And so what you'll find in the next presentation when Stephen talks about what this program could look like in the future, I think you'll see PMAC was really mindful and really intentional on how it tried to incorporate or address diversity, equity, inclusion, and how the program itself was structured.
Thank you.
All right, let's move forward, please. All right, so just wanted to, there was a follow-up question within PMAC about further articulating best practices, so we put this in here as reference material. Ron Getzel published these in the International Association of Worksite Health Promotion journal, and these are very similar to what we presented on the previous slide, but just wanted to have another cross-reference for best practices, and you can use this for your reference. But we've talked about the importance of culture. Did you see number one on his list? Gaining that leadership commitment, setting reasonable goals and expectations. So having that written strategic plan, providing those strategic communications in a timely and multimodal way, engaging employees in program design and implementation, so surveys and focus groups, which you have and are incorporating, implementing best practice interventions. We've talked about the importance of best practices, effective screening and triage. So here's where we're talking about, let's help identify what the needs are from a diversity, equity, and inclusion perspective, as well as other filters, and help people get to the place that they need and get the right support in a way that's meaningful and acceptable to them. Offer smart incentives. So this is that point about extrinsic incentives are good to encourage short-term actions, but we ultimately want internal motivation to take over for long-term behavior change. And clearly, this needs to be implemented in a way that all of the wires are soldered together so that data from various sources is integrated, and ideally we have a centralized platform and entry point for people to engage. And then measure what you expect, right? Measurement and evaluation. Set goals and targets for key metrics and measures, not only around financial return on investment, but also the VOI, the value on investment. So consider the impact on attraction and retention of talent, and lowered disability claims, enhanced productivity, better mental health, and other advantages to the organization. So again, for your reference there, and I don't know if you intend to have a break before the next schedule or not, but that's the end of this part of the presentation.
We don't have a break scheduled until 11:05, so I think you can just continue through if that's okay with you, Stephen.
Absolutely. This is just some more reference material. I'm not going to speak too much to it because the actual dollar amounts are dated. You can see that we're talking about what the incentive amount is throughout the year for different organizations. This is 2015 data. I pulled data from the most recent HERO scorecard database, and the mean incentive value across all size organizations is about $500, just a reference point for you to consider. All right. So now we're taking everything that we discussed in that initial part, and quick recap. Because repetition helps us solidify the key points that I already made. More engagement drives better outcomes. More best practices yields more sustained engagement. Extrinsic motivators encourage initial participation, but intrinsic motivation is crucial for sustained behavior change. Offer a variety of activities and multiple modalities to drive broad engagement across the population, and allocate the majority of the incentive budget to healthy activities that drive higher engagement. So if there is health assessment and screening, some initial gateway activities, clearly don't focus the incentive just on those. Spread it out throughout the course of engagement and time. And then we already discussed the core report from PEBB's HEM program, and we gave you an initial view of other employers' structuring of incentive programs. And we're going to go through a little bit more of that now as we put this into motion and put some real life experience around some of how this could look for the future of HEM. So again, we focused on Model 3, which I presented in the previous deck. And by the way, while this is, the intent was that we were going to present that deck that I just went through the last month. So that's why we repeated some of this information in this deck to bring in previous episodes. This is the previous episode. So again, I won't spend a lot of time on it since we already talked about this, and points 3 model is the one that we're focusing on for the future HIM model. So you can forward to the next slide, please.
Yeah, and just a note, in terms of what would work best, Model 4 just felt like a bridge too far for the committee. It's, compared, if we were to move from today's HEM to a new HEM, Model 4 felt like it was such a huge change. And I would also say with Model 4 comes some increased administrative complexity that would be on the staff and administrator as well. So just to note that 3 just felt right.
Right, thanks, Brian. All right, so the future HEM program. So this is a high-level description of what the current proposal is from PMAC. This HEM model is designed to be a multi-year program with activities that can earn annual monetary incentives. We've selected a 3-level model that provides incentives to do various activities that are available to members, and they can work through these in a sequential order to get the different levels based upon completing different activities, and the incentives would be accumulative. And we're going to play this all out in actual examples in the following slides. This is just the initial introduction. Members can decide whether or not they want to stay in the same theme or path year over year, but if they choose a particular path, let's just say they're working on a person that has diabetes and they're in a condition management program for diabetes, they could continue to focus on that year over year. Administration, we intend that there be a single wellness program vendor platform that administers the various components of this program, that takes the administrative burden off of staff and simplifies the experience, quite frankly, for the member. And then we know that PEBB would have to conduct an RFP to find that vendor to do that work. And it's very clear that this is going to take some time. This isn't going to happen in the next 2 months. It's going to happen in probably the next 2 to 3 years. It'll take time. And Brian, if you have any comments about that process.
Yeah, I think it's probably important just to say a few words about the single wellness program vendor bullet, in that ideally this vendor could be more encompassing than just the HEM program. We have a lot of different wellness programs that we currently source, through our carriers or sometimes directly. And so I think we'll get to in later presentations, but when we talk about a single wellness program vendor, I think the intent is to be both a HEM administrator and to do some other wellness program administration stuff that we currently do not have the capability of doing or the resources to do currently.
And Brian, I just had oh, go ahead.
I was just going to say the goal for members is to provide one-stop shopping. Nice, convenient location everyone would go to, where members wouldn't have to go to PDB to select a program and then a carrier website to take an assessment. Everything would be in one place. And Siobhan?
Yeah, I just had a question of whether any kind of preventative care, like the things people are supposed to do, screenings, getting, dental cleanings, getting a flu shot, are those pretty much part of any of these paths so that people would be doing the things that are recommended for their wellness prevention wise?
They could be, and we'll talk a little bit about sample requirements, I think, in a couple slides, but we don't talk a lot today about specific program requirements because, frankly, this is a long-term program that could take a couple, 2 to 5 years to implement. So we didn't want to get too hung up on what programs are today. That said, I think there are a whole host of program requirements we could build in to this program going forward that would include things like potentially, have you taken your dependent for a dental screening this year, or a vision exam?
Thanks.
And I'll just say, as an example, most of the well-being vendor platforms, the leading well-being platform vendors that you would probably consider to be that administrator, do have those built in to their incentive model. So literally, they have modules within the different activities that you can select to offer to your membership that would allow people to say, I've completed these U.S. Preventive Health Task Force Services recommended preventive screenings, and you can either do that by self-attestation or some other form of verification. And you could even embed, if you wanted to, giving people credit for achieving biometric outcomes. Again, we're not necessarily recommending focusing on those per se, but that could be a bonus if you actually achieve healthy blood pressure and healthy BMI and so on and so forth. So yeah, those things certainly are available in these platforms and could easily be included. All right, some of the suggested themes and paths, again, as Brian just said, this is a skeletal view, and all of this subject to modification as the program is fine-tuned and rolled out. But the paths and themes that are currently envisioned are condition management. I gave an example of diabetes management program, physical activity for all abilities. So again, we want this to be inclusive, and nutrition, healthy work environment, community and family wellness, emotional health and well-being. And we'll elaborate more upon those ideas in the future slides here. So if you'd move forward, please. So this is a further iteration of the structure and how it would work, starting out with the highest level here to describe that this is a 3-level model over the course of a year. And we have broken it down into keywords to describe each level. The first level 1 is to assess where you are right now. Level 2 is plan what you want to do. And level 3 is take action. So for level 1, and we're going to put specifics on this in future slides. So we'll give you examples of what we actually mean by this. But you would fulfill the activities for level 1, the assessment, and you would receive level 1 rewards beginning effective January. And right now it's envisioned that these would be payroll contributions, cash equivalent in the payroll. But all of that's subject to discussion and decision. Level 2, you would actually do the planning that's required for the activity, and then you would get an additional incentive on top of your level 1 activity that begins effective in April. And then final 3, taking action on some verified action on some of your planned activities would occur at level 3, and that would give you the 3rd level of incentive, cumulative with levels 1 and level 2. Level 3 is effective in July.
Yeah, and just a note on the timing of the incentives. So first of all, it'll take some time to work through the program requirements in each level. But also from a budgeting standpoint, there may be ways that the board would want to play around with when and how the incentives are structured going forward. to lessen the budget impact. So maybe the highest level incentive, a member could earn, monthly after they get through all levels. And I'm just throwing a number out here, but let's say it's $50 or $75 a month. Well, if they can't actually qualify for that whole $50 or $75 until July 1st, that just gives us a little more wiggle room with how we budget the program, if that makes any sense. And then Stephen also noted that we're contemplating cash incentives. That said, we don't get into the specifics about what the overall incentive structure needs to be for this. I think the message that PMAC wanted to make to the board is this picture that we're going to paint of the future program or what it could look like will require members to do more activities, to be more engaged. It will be a slightly heavier lift than they have now for HEM program. But as a result, we need to put out a more robust incentive structure. So it's kind of a give and take. And that's going to be a pretty tough, I think, challenging discussion and eventual decision for us to make, with the board is what overall levels of incentives are appropriate given the additional efforts we're going to ask the members to make and the priority this program could have in future years.
All right, if we could move to the next slide, please. Thank you, Rose. So now we're putting a little bit more meat on the bones in that level 1 requirements. Examples, again, these are not set in stone, but examples for the sake of how this could look. A member could register for HEM on the Wellness Vendor Portal, so they register on the platform. They can complete a health assessment, could be a health assessment questionnaire online or a biometric screening or both. And ideally, those kinds of assessments occur early on in the year so people are aware of what they could do and they can use that information for planning in level 2 and see progress throughout the course of the year. And then the final requirements for level 1 are to complete 2 health or wellness related training courses or modules, again, available on the platform. Then moving to level 2.
Sorry, Stephen, just a note on the training related courses or modules, PMAC, in the interest of level 1 being assessment, some of the things that PMAC talked about is developing modules that would actually help inform members how to access care. I mean, actually, how do I see a specialist or how do I get in to see this type of provider? So really make it about education, help the member figure out what's going on with them, how to access services they need. And that would be kind of the theme of the level 1 requirements.
Thanks, Brian. Then moving to level 2, this is the planning phase. So pick an annual theme or path that makes sense for you. Develop your personal wellness plan. Select at least 4 self-attested activities based upon the theme chosen for that year, and 2 verified activities based upon the theme. So the self-attested could be activities like tracking your sleep if it's not verifiable. There's some apps that actually allow you to measure sleep time, but I'm just going to use that as an example of, or hydration, how many glasses of water you drink in a day. Would be examples of self-attested. And then verified activities could be actual, if you have a Fitbit or an Apple Watch that measures your steps or activity, that could be a verified activity or a module on the website. And then finally, level 3 is taking action, complete those verified activities and get the rewards for those. So any questions about the intention of the assess, plan, and act levels? And if not, we'll move to some examples. So we've developed 3 different personas to give you an example of what this would look like for a real person. And I'd like to introduce you to Sarah. To begin with, Sarah's a program manager. She uses a wheelchair. She lives in Eastern Oregon, and she's a remote worker, so she works from home. In that level 1 assessment area, Sarah, after November 1st, registers on the Wellbeing portal. She completes the online health assessment on the portal, and then she completes 2 of the available training courses on the module. So as Brian mentioned, these have been designed to really help people know how they can access other services. So she selected accessing healthcare in rural areas and healthy meeting guidelines. Sarah then earns level 1 incentive that will begin in January of the next year. Then after January, Sarah selects, and this is a select phase, planning, community and family wellness as the theme for her personal wellness plan. And she selects 4 activities to include in her plan. Excuse me. Donating blood, joining a community group, doing gardening with neighbors, and getting dependents in her family to complete annual dental checkups and cleanings. And once she does those, makes that plan, she gets level 2 incentives beginning in April on top of her level 1 incentives that started in January. Level 3, after Sarah finalizes her personal wellness plan, she is starting to actually complete the activities. She completes her selected activities by June, and in addition to her level 1 and level 2 incentives, she receives the level 3 incentives beginning in July. Any questions about that example and Sarah and how she would move through the 3 levels to get her full incentive?
So level 2, the plan, those, she just reports them. That's not anything that anybody can verify. I mean, we don't try to verify it.
Well, it could be, excuse me, it could be verified in the sense that it could be tracked on the plan. So she'd probably be selecting this on the Wellbeing portal. So it's probably not something you would track, but it would be recorded is probably the better way to say it. But it's not going to be verified necessarily.
Yeah, level 2 is just coming up with what your personal wellness plan is. You don't have to do any of the activities in the plan, but you would select, under your theme and path, you would select your theme and path, and then by implementation time, there would be probably a whole host of requirement options that would be populated under that theme and path, divided up by activities that are verified and those that are unverified. And as part of this program design, we would just specifically determine the number of verified and unverified activities members would need to complete, and then they would select those numbers in their wellness plan. And once they've made those selections, their wellness plan has been customized for them, and we would consider level 2 complete. And then level 3 is just actually executing that plan. And again, nothing requires members to move through all 3 levels. So it's possible someone moves through level 2 and they're like, I don't have, the energy, or I don't want to go on to level 3, but it was helpful just to design a plan. And we would say, that's okay. That's, it's somewhat going to be self-directed. We would love it if members move through all 3 levels. But at least now the way it's structured, it gives a little more flexibility and self-direction.
Well, and it seems like at some point we could then ask what were the barriers for why you didn't go from level 2 to 3? I mean.
Correct, because at the end of the day, it is critical that members follow through on this stuff, because these are the outcomes and the activities we want them, doing to support their health and wellness. I guess what I was saying is, in and of itself, having members choose not to move on to level 3 for incentive purposes, in and of itself, shouldn't be overly concerning. It's really about the whys. And again, some members just may not complete all 3 levels, and at least for the first few years of the program, at the very least, we should be able to gather more data and information about what is and what's not working for the program and our membership.
And I'll just give you some real life examples, because I have clients that have models like this in place. And we do indeed assess how many people are making it to level 1, how many are making it 2, level 3, and then we try to figure out why aren't people getting further. And sometimes, and then you can even do things, and again, this is more complex than we would do in this initial design, but as you assess the data and assess the engagement, there are ways to give bonus points for doing things further on. So we can help push people to the next level by enticing them with bonus points for doing multiple activities or doing something with a group. Or my whole work group does this and we get 60% participation from my work groups, so we all get bonus points. It can be very creative. These platforms are quite flexible, and truly, just as you said, we want to read the data and see what it tells us, try to assess what's the root cause for why it's not everyone's going to where we hope that they would go, and then adjust accordingly. All right, let's move on to meet our next employee. And our next employee is Maya. Maya is a woman of color. She works at a state agency call center. She lives in the Willamette Valley, and she has concerns about accessing health services. So Maya's level 1 activities include registering on the Wellbeing portal. She completes the online health assessment on the portal, and then she completes 2 available training courses there as well. And the training modules or courses that Maya chooses are tips for creating and sustaining a healthy work environment and weight management. And you'll see that Maya has diabetes, so weight management module seems to make good sense for her to learn more about that as well. So completing those activities, Maya earns level 1 incentives starting in January, and level 2 is now available, and Maya selects condition management as a theme for her personal wellness plan. And she does decide to join the diabetes management program as an area of interest on her Wellbeing portal. She also selects depression as an area of interest in her Wellbeing portal. By the way, oftentimes people with chronic conditions also suffer from depression. So Maya may be feeling some of those things. By the way, to that earlier point that Sean made about confidentiality, none of this is known to any of you and any of us. This is all managed via HIPAA privacy regulations by the third-party vendor. That's why you have a third-party vendor or carrier doing these things. So we're just looking in over Maya's shoulder. She's allowed us to look at what she's selecting here for the sake of this example. And Maya enrolls in the diabetes management program that's offered by her health plan Providence. And that data about her participation is fed back into the Wellbeing portal so it can be verified and tracked, for example. And she also calls the EAP to understand what kinds of support services are there and available for her. And then she earns her incentive for level 2. That's added on to her level for incentive 1, and the level 2 incentives begin in April. And then level 3, after Maya finalizes her personal wellness plan in January, she starts to actually complete the activities and completes those selected activities by June, and then she gets her 3rd level incentive beginning in July. Thoughts or comments? All right. Now we'll move on to one more person. And we'd like you to meet Jim. Jim is a man of color. He works as an officer at the Eastern Oregon Correctional Institution. And Jim also is choosing to participate in HEM, and he starts after November 1st to register on the Wellbeing portal. He visits his primary care physician. Now, he decided not to do the online health assessment. He decided he wants to go to his primary care physician, and he gets blood work done, and his physician faxes in to the Wellbeing portal the results of his blood work. So Jim gets credit for that. And then he completes 2 of the available training modules. He chooses to review his agency's worksite wellness plan. And he's also interested in looking at an introduction to health equity and inclusion. Completing those activities, Jim receives his level 1 incentives beginning January of that next year. And then after January 1st, Jim selects his plan of action he chooses physical activity and nutrition as his theme, and then selects 4 activities to include in his plan. He is one of those guys who likes to use his Apple Watch to track his activity. So he synchronizes his Apple Watch on the platform. He sets a weekly step goal, he sets a weekly activity goal, and he sets a daily sleep goal. All of these things available through his Apple Watch or self-report, and will all be rewarded on the platform. And then, completing that planning, Jim receives level 2 incentives beginning in April. Level 3, Jim now takes action on his personal wellness plan and starts to complete the activities. And when they are complete by June, he receives level 3 incentive beginning in July. Any thoughts or questions? So hopefully you saw that there are a variety of ways. People chose different paths. They chose different things to do to complete the requirements in level 1, level 2, level 3. So again, trying to show there's flexibility in the model, hopefully something for almost everyone, and it'll be easy and meaningful to engage. Brian, do you have any comments here?
No, I was just going to comment the variety of program requirements that could be built into this are really widespread. I mean, there's a lot of flexibility that this structure could accommodate. And so there are even a lot of program requirements for level 2, for example, depending on how fancy or complicated we want to get, that could include kind of claims-based services. So maybe going in to see your family doctor. And that's something that the wellness vendor could interface with the carrier and be able to confirm. So from that all the way to setting your own step goals, to taking cooking classes, I think the overall structure just allows for us to come up with a whole variety of program requirements that could speak to probably more members than we currently do.
And I think the other point that this makes is one of the questions from the board previously was, should there be a list of things that people can choose from? And the evidence suggests that there probably should be a curated list. It shouldn't be wide open, free for all, because then people don't know what to choose and they paralysis by analysis, right? But here we've got somewhat of a curated list of activities that people could and should do, and they can still have that element of choice.
And also just PMAC, based on all of our discussions, does envision there to be a set of unverified activities that are part of the program requirements. In other words, it's still our ability to give that sort of personal flexibility to come up with things that aren't necessarily audited or wouldn't be appropriate to follow up on, but could be important to members, and still give them that the flexibility to come up with the plan that works best for them.
And I probably would just also say that while we've given you some specific examples here today, all of this is for the sake of showing you how it can work. The unknown right now is which vendor or vendors will be selected to administer this and what their capabilities are. So some of this may be subject to modification, either expansion or contraction, but rather than being limited by a vendor that we don't even know who it will be at this point in time, we gave you some examples that we believe are practical, could be delivered on all of the best-in-class vendor platforms that are available in the marketplace today. All right, would you move forward to the next slide, please? So here's just an introduction or a overview of how we see this going through the course of time. And again, as Brian has mentioned, this is likely to be a 3 to 5 year process for initial procurement of a vendor, finalization of the model, implementation and rollout, and then adjustment as time goes on. But so this very first year, we would suggest that there can actually be parts of this model that can be implemented early on and then adjust over time. The year 1 transition year is designed to be relatively easy, We want people to get comfortable with it. So complete level 1 activities, encourage completing activities in level 2 and 3, but we recommend that people automatically get levels 2 and levels 3 if they complete level 1 in this year 1 transitioning from current HEM to new HEM model.
And this was a really important point for PMAC, particularly those members who remember how the original program was implemented. And so the thinking is, if there is a way, if the board wants to implement this sort of updated program, if there is a way to be able to accommodate in our budget, giving all participants full incentive payments that year 1, as if they move through all the incentive levels and met all the program requirements, while still messaging to them how to move through levels 2 and 3 throughout the year, could just give the best experience for members in terms of transitioning from our current program to something that is going to ask a bit more of them. Does that make sense? I feel like I wasn't as clear as I could have been.
I think so. I think I caught what you're saying. So you would do the January, July, those different, you would roll even though they maybe didn't do them yet. Is that what you're getting?
All members that would meet those level 1 requirements and would qualify for the level 1 incentive would automatically be bumped up to level 2 and 3 incentives when those open up, regardless of whether they actually completed them. At the same time, the program vendor would be asked to still heavily message the membership about levels 2 and 3, saying, hey, next year is going to be different. So this year is all about getting you guys used to this additional program. And PMAC thought that if we could make that work from a budget perspective, it may be beneficial for that first year implementation.
Another question, not to be sorted out right now. I understand this is a long time, but another point is, one of the challenges we've had with communication is ununified communication, like too many communications coming from too many sources about similar things, but they're different. So one question to tackle, I guess, at some point would be what happens with the current carriers' messaging and their attempts at health engagement and whatever. It's like this platform gets privilege, versus those, that kind of thing. So that would have to be sorted out. Of just raising it for a future topic,
Yeah, and Sean, I would envision that to be included in all of our implementation discussions. If the board is interested in moving towards this type of program, when we get to the point of actually trying to design the program, we're going to have to work with this wellness vendor to determine what sort of program requirements are out there. And within that universe of options, we'll include various programs and services that our carriers provide. So there's going to be a need to work with both the wellness vendor, medical carriers, and other service providers to make sure this does end up being one-stop shopping, things are coordinated. And also, too, there may be things that the medical carriers do that we don't want to take out of their purview that they do and do really well. So I also think we want to be very conscientious when we get to the point of designing the program in those particulars.
Yeah, we see that handled in a variety of ways because most, all the clients I work with have medical carriers, right? And all those medical carriers do have some well-being services, but when all of the clients that I work with do have a centralized well-being vendor, and the things that the carriers do are, as Brian just said, usually very much curated. If anything if we depend upon the carrier to do some piece of that, the entry point still is the centralized well-being portal. and they're directed out either by link or single sign-on to that very specific service that the carrier is providing. I'll just speak from my own experience. I don't know if your experiences are the same with your carriers, but I don't get too many communications from my medical carrier about their well-being services. And they generally don't do that much on those. There may be some targeted outreach for chronic condition programming, but again, those kinds of specialized services we would expect to be delivered or linked to directly to the well-being platform, because we also want members to get credit for those activities. So that we'll set up a data feed from the carrier to verify what that member did using the carrier resources that gets reported back to the well-being platform. So again, the member is going to be focused on, I did this and I got the reward on the well-being platform. I didn't get any indication that I did it or completed it on the carrier's platform. So, but to Sean's point, communication is going to be crucial and vital. And there may be some communications that you could actually ask the carriers to turn off to your members if they do conflict. But you do want to have a comprehensive strategy for communication that addresses where people should go and how they can easily engage in the services that are intended for them.
Yeah, and we'll even want to have conversations about marketing and branding this program and whether we continue it as, the health engagement model, or whether it makes sense to, update it. So I think if you want to move forward in this direction, there will need to be a very comprehensive communication strategy that includes all of the above.
All right, so one other feature of the year one transition year is to still keep this somewhat linked to open enrollment, because that's what members are used to doing, is to signing on to HEM through the open enrollment platform. So what would happen, as we envision it, is to have a landing page or a page that shows up an open enrollment that people click on and go right out to register on the wellbeing portal. So that's how we could link it to open enrollment. All right. So moving to year two, this is the adjustment year, as we're calling it. So this is the year that people start to move into the newer model by choosing the theme or path for this year. Could be the same path that they were on, or choose a new one, and actually start completing activities to reach levels 2 and 3. And then you can see the bottom part of that panel suggests that we're going to read the data, see what it says about what people did, what they wanted to do, what they didn't do, and then decide on adjustments for the future. At this point in year two, we envision uncoupling or decoupling HEM from the open enrollment process. So the communication would be people need to go to the wellbeing portal to register or to continue their work.
And just to note, for the year 3, when we talk about gathering data and really evaluating the program, we would expect that the wellness vendor would be able to do a big portion of that along with our consultant. So again, I think an advantage of having a wellness platform vendor and one-stop shopping is hopefully their increased ability to evaluate that program and better determine its effectiveness, and hopefully allow us to make more real-time adjustments that can be effective from year to year after we get through those first 2 or 3 years.
Mm-hmm. And I'll just say a note about, again, talking about the best-in-class well-being vendors out there. We typically see that there are a variety of reporting that they do that talks about registration, talks about engagement over time, talks about impact and outcomes. And some of this is done on a live, real-time portal that your staff can actually go to and see and look at this data any day, anytime they want to. And then on a cadence, monthly, quarterly, annually, the vendor highlights some additional data and makes a presentation about what they're seeing in the data that we can react to and adjust to. So the reporting these days has become very robust. And then when you combine that, and there'll be choices even to make about whether or not you want to merge in claims data, medical and pharmacy claims data. And that's a possibility too for an even more robust evaluation of the impact of participation in lifestyle, well-being, and utilization and cost for healthcare.
Well, Stephen, I think you timed that just right. Do you want to take, before you start your next slide, should we go ahead and take our 10-minute break? Everybody stretch, get some hydration, and we'll be back in 10 minutes. Thank you.
Thank you.
Kimberly, Jeremy,
Yes.
Jeremy got hung up in a legislative hearing this morning and asked pass along his apologies for not being able to make it.
Oh, okay. Thank you.
Yep.
And Kimberly and Ollie, just so you know, I have to step off at 11:30 for a meeting that popped up. So you see me leave. I send my apologies.
Okay, thank you.
Do we have, Kimberly, are we still going to have a quorum after 2:30 or after 11:30?
Yeah,
Okay.
Yes.
we'll have 5.
Okay. I was going to say, if not, we could probably get some action now and then return to discussion, but it sounds like we'll be fine.
Yeah.
Have we heard anything from the senator and the representative? I know that they're busy. Are they picking replacements? Are they going to be active at any point, or?
Rep Salinas is usually at the meetings or sends a delegate.
Okay.
I think the past couple there's been conflicts, but as far as Senator Johnson, you know, I think you know, we've pursued that in the past and haven't had any luck, and I can definitely pick that up again.
I'm just curious. Didn't know if we needed to connect to update, or they get the same emails all the rest of us get and the packets and that kind of thing, and have the ability to speak up.
Yeah, they get everything that everyone else gets.
All right, well, we're a little over. So is Stephen back? Or are you talking, Brian? Are you up? Oh, nope, there's Stephen.
Yep, I'm back, but I think Brian is going to take this section.
Oh, perfect. Thank you.
You're on mute, Brian.
Yeah, I was just going to ask you if you had any other thoughts or comments before turning it back over.
No, I'm open to any questions from the board, but I think I made my closing remarks at the end of the last section.
Great. Okay, so thank you very much, Stephen. So really quick, recapping kind of this future vision for him. Again, unlike other recommendations, we didn't include a lot of program specifics. We really tried to paint a picture of how this could be structured. So in terms of the highlights, this vision of him contemplates having 3 different levels that would be administered annually. Each level with its own incentive, but those incentives are cumulative. So as you move through levels 1, 2, and 3, those incentive amounts you earn are added on top of each other. Level 1 is about assessing your situation, taking some sort of biometric or screening, maybe taking some training courses on how to access services. Level 2 is tied to planning, coming up with a wellness plan based on what you learn in level 1 and coming up with some verified and unverified activities. And then level 3 is about acting, taking that wellness plan and actually executing it, following up on those actions and completing the wellness program or wellness plan. Another note, the way this is structured with the themes and paths and all those different levels, as you can see, there's a ton of room to add a whole lot of program requirements that could speak to our members. So the structure is set up to where I really think we could have a lot of robust discussions in the future about making sure the program requirements are comprehensive enough to speak to our diverse membership. If you do want to move this forward, again, this is a long-term program, and I do think when we will have to return to the board at some point and talk about some of the program design. And specifically, I just want to highlight that I do think some future discussion that the board will have to have some future discussion about what the appropriate levels of financial or other incentives are if we're going to ask members to do more, increase their levels of effort for this type of program. And again, that was something that PMAC wanted to highlight as a future discussion that needed to be had at some point, is trying to find that sweet spot with what sort of levels or incentive levels we provide to members compared to the levels of effort they would be required to actually get those incentives. And just the last, I think PMAC did a fantastic job at proposing how this could be implemented in light of how HEM was originally implemented and rolled out. I think PMAC just did a really great job of being very conscientious about how this will impact members, even members who are completely on board and excited for a program update. And so some of their ideas they have for year one implementation are also things we'll want to discuss with the board if you want to move this recommendation forward. So now we're at the point of the presentation where I am going to talk a little bit about the challenges associated with implementing this type of program. Before I do, are there any questions from the board before I jump back in? Okay, and so not hearing any. So now that we've painted a picture of what this program could look like, we'll need to identify the various challenges that we'll need to overcome to get to this future state. If you recall from last month, part of this assignment was to identify challenges to implementation, but not necessarily let them stand in the way of what the final recommendation would be. So we're tackling these challenges just in a separate presentation, knowing there are things that we're going to have to work through, and they're just part of our standard program implementation. So with that said, next slide, please. Okay, so if the board is interested in pursuing this future vision of HEM, we'll need to plan for various implementation requirements or needs. So for example, we'll need to develop and administer a large RFP, and Stephen touched on that earlier. We'll need to work on incorporating or interfacing with various existing state systems and infrastructure, such as Workday or payroll. We'll need to ensure compliance with ACA and various other regulations like the ADA and various tax regs. And we'll need to ensure we can cover all of the implementation related costs for the project within our budget and limitation. So next slide, starting with the large procurement. This is the first major challenge I mentioned associated with implementing this proposal. So the future vision of HEM contemplates having a single wellness vendor administer this program in a way that provides members with that one-stop shopping experience for both HEM and hopefully for other wellness programs. This would undoubtedly require some sort of competitive RFP. Some of the issues that we would need to work through regarding that RFP would include, does staff currently have the resources to design and administer this RFP given other priority work? Or will we want our consultant to play a major role in assisting design and administration of this RFP? What type of procurement makes the most sense? Would we want to move this forward as a standalone RFP, or do we envision this as being part, maybe a component of a larger, more comprehensive medical RFP in the future? What other priorities could PEBB be facing during this implementation period, and can we reasonably move through this sort of project or RFP, unscathed, being able to get to the finish line? Excuse me. Okay. And then given that this is likely a long-term project, we will need to re-examine the evidence and industry practices as we get closer to an RFP release. So next slide, please. So the next implementation challenge I'd like to address relates to how this program will need to work with or incorporate existing state infrastructure or systems. So what infrastructure are we talking about? So currently, and I would presume in the future, that the incentive payments would go through payroll. So we're going to have to continue working with payroll. We should also take advantage of any existing training systems that exist for our membership. So I know many state employees use Workday. However, it's important to note that other groups like the universities do not. So Workday might be able to accommodate training requirements for this program for certain state employees, but it wouldn't necessarily be a global solution. And then we'll also have to keep in mind that there could be various program requirements members could choose from that involve medical services. So I had mentioned earlier, potentially visiting your primary care doctor. So in that case, we would need the wellness vendor to be able to interface on some level with our medical carriers, dental carriers, or other vendors. Any questions so far? Next slide. Okay, not seeing any. Oh, go ahead.
All right, I didn't get to the mute button fast enough there. So this point about payroll. I mean, would it go through payroll? I mean, I don't know if payroll has the ability to do varying
So they
cash outs depending on month to month or even quarterly to quarterly variations of activities, you know? Like I don't know if they could absorb it. So like what if it's the cash payout is more like like a gift certificate or whatever to some variety of things or something like that. I mean, is that out of the question? I mean,
no, it's not.
It's administrative
So again,
easier.
So again, Sean, I think if this is a program that the board is interested in, we're going to need to have some additional discussions with the board about the specifics. And this is certainly one of them is the incentive structure. We've assumed and presumed that cash incentives will probably be a big part of it because that's what has kind of historically moved the needle with members. However, as PMAC noted, that this is a conversation that the board needs to have if we move this forward, because it's going to be a challenge. Is what sort of incentives do we feel will be robust enough given the levels of effort required?
And Brian, the payroll system is actually being replaced. So currently, you're right, Sean. It probably couldn't provide what we'd need, but in the future Workday module. I would hope that it could accommodate a little bit more complex kind of wellness component, but again, universities may have different kinds of issues.
That makes sense. I appreciate that. The other thing, just related to the extrinsic motivation literature, I would be curious about just talking about this specific component here of how do you pay people things. Yeah. A lot of people have direct deposit. I mean, you're kind of encouraged. I think almost everyone that works for the state has some kind of direct deposit situation, that the state sets up. So it's not like you literally get a check and you look at the check and you sign the check and then you're like, gosh, this check seems a little bigger than that, that sort of thing. It just kind of ends up in your bank, and a lot of people will take a really close look at that probably, but some people probably don't, as opposed to like, click this button and get $50 because you did the thing, those are two very different types of reward systems. Even though it's the same amount of money, it's like the way you gave it to the person felt different, if that makes sense. So anyway, just as we're thinking through that, that would be another question, like, does the literature have anything to say about that? Or
Yeah, I can speak to that, Sean. You're right. I think the behavioral economics concept suggests that putting something out there that people can see regularly, that triggers their action in the first place, and then their reward for it, somewhat Pavlovian in a way. But indeed, being able to see it, and you're right about the payroll systems of today. People are getting direct deposits and might not even recognize it's there. There is, as I mentioned in the earlier presentation, the well-being vendors of today, most of them have a marketplace that's directly integrated into the platform so that you see your points, that you were rewarded from doing the activities. You see the dollar amount that you have available to fulfill. You can use it immediately or let it roll over and go for a bigger merchandise or a bigger gift card. But yes, you can literally click a button and say, I want to get a gift card that I can use any way I choose, or I want to make a charitable donation to this charity, or I want to buy this piece of merchandise. I want to buy that Apple Watch that I've been waiting for. So yes, that's definitely a possibility. I think that the cash reward is the current model, and that's probably why it was embedded in this initial iteration of the model. But clearly, the well-being platform gives you a lot more flexibility to do something like the marketplace as an alternative.
Okay,
And,
thanks.
and then Sean, to your question about the payroll system. So PMAC did ask us to meet with payroll and with Workday just initially to make sure there was nothing about this that would outright blow their plans up. And actually payroll, it seemed like that was the easiest path we had. That for payroll, if it was just a matter of there being, 3 different levels of incentives and we're just sending them, or the vendor sending them files on, which members are earning those incentives every month, that it may not be a huge deal over current practice. That said, again, payroll isn't the only payroll system involved with PEBB members. So it's kind of like Workday, where we have a huge or a group of PEBB members that we're going to have to find solutions for, that just Workday and payroll doesn't make sense because they're not truly in the state system. So this is all part of the implementation work that we're going to have to figure out, plan for, and then partner with the universities and other stakeholders to make sure that this can speak to all of our membership and not just specific groups. Okay, so we also should talk a little bit about regulatory compliance. So there's numerous regulatory schemes or legal requirements that would apply to this future program. And we'll need to carefully weigh them and work with our consultants and legal counsel on how we design the program to ensure compliance. Some of these areas include ADA requirements, including offering reasonable alternatives, various IRS regulations tied to cash incentives and incentive payments, and various ACA and wellness program regulations that apply to a program like this. Next slide, please. So the last implementation challenge I mentioned relates to the cost of this recommendation. And I think costs are generally kind of bucketed into 2 groups. There's the startup costs, and then there's the ongoing program or maintenance costs. So first of all, there's going to be a lot of different costs associated with developing and implementing this type of program. For example, the cost of the wellness platform itself, the cost of building any needed interfaces with the other systems that I just mentioned, or even updating current systems to be able to support some of these new program features. In addition to these types of costs, there are also the costs associated with staff time and resources that will be needed when we're designing, developing, and implementing this type of program. Next slide, please. So this slide shows the ongoing costs that are in addition to these development and implementation costs. So these type of costs would include the ongoing wellness platform vendor fees, maintenance costs, or if we want to make certain added functionality or changes to the program itself, there may be some additional programming costs over time. Whatever costs would be associated with the enhanced incentive payments or incentive structure that we would want to tie to this program. Cost of other types of program incentives if the board goes that direction. So Sean mentioned gift cards, for example. And just the cost of adding other programs, maybe wellness programs, that could speak to various program requirements or fill some gaps we feel exist currently in our wellness program offerings. So we've already talked, I have a note here on my slide to be sure I mention future discussions on, again, incentives versus levels of effort. So I think I have, I think I've mentioned that a few times enough already. We know that we have a lot of discussions we'll have to have if the board wants to move this forward, so we can figure out how to design and implement this program. So that is the end of this slide deck. And next slide, I will move right into the next steps. And before I do, let me ask, are there any questions so far? Not seeing any. Okay, so one second.
This is Sean again. Sorry, I'm slow on the draw today. I don't know why. So, speaking of costs and paying for this and such, is there any thinking back through all the presentation today and last time do we have any information about this particular model, which is closest to like, I forget the way you worded it exactly, but it's like the third model. Reasonable expectations around return on investment kind of analyses. Like there was an attempt to do that with the analysis from the previous HEM that we have. As you pointed out, there were limitations to that where it really wasn't even a natural experiment in that methodological sense, because there were so few people that didn't participate, that proportionately those people were quite different. But in the literature, is there any like, even if it recovers some of the costs, even if it doesn't have a classic return on investment of like 1.5 to 1, even if it's like, well, of what you invest, you get 80% of it back or whatever, so over a 5-year period the actual cost is more like this. Is there any kind of analysis like that that you're aware of?
Yeah, there are a number of analyses in the literature with varying methodologies to come up with that number. One that I'll just reference that looks at claim costs, because I know this is also integrated with your vision of containing costs for the healthcare organization, for the organization as a whole around healthcare. We conducted a validation study on using the HERO scorecard. I referenced the HERO scorecard earlier. A few years ago, when we initiated the next version of the HERO scorecard, we used the database of scorecard completers and those organizations who scored high on the HERO scorecard, and again, relating not the score on the scorecard to more best practices in place. So high scoring organizations compared to low scoring organizations, and what the association was with their healthcare costs over time. Over a 3-year time period, those high scoring organizations that had more best practices in place had a minus 1.6% trend, cost trend. And those that had less low scores or fewer best practices had no impact on cost trend. It stayed flat. So that's an indirect suggestion that, again, more best practices are going to dictate the likelihood of financial impact and health improvement impact. If you ask, is this particular model, will this particular model get you to the highest possible return on investment? I would say this is an intermediate step toward that, but probably not the most robust step to get there. That most robust model would probably be the 4 levels within each quarter, because it requires people to keep doing something every quarter and draws them along throughout the year. This model, I think, is still a good intermediate step to get there, but I would set the expectation not at the highest level. Now, what is the highest level is your next question in terms of return on investment. The literature suggests that return on investment for well-being initiatives can be somewhere between 1.5 to 2 to 1 return on investment over the course of 3 to 5 years after implementation. So it's a longer time horizon when you consider the preventive aspect of the well-being initiative. There will be chronic condition management aspects of this too. So we're probably looking at more of a blended ROI for helping people that have high costs right now because of not well-managed chronic conditions and also preventing people from moving into that state, which has a longer time horizon on ROI. But I think, Sean, you asked it fairly and appropriately. Would you at least expect to receive one-to-one, cover your costs? And I think with this model, you could at least expect that, if not more. But that's depending upon people actually meaningfully engaging, choosing the right things in their wellness plan and acting on them persistently. But it has the potential to do that.
And I think you would really need that kind of information if we're talking about a budget request that would need to go to the legislature, which for additional budget limitation, we would need to put a policy package forward, and having that return on investment would be super important because, you know, there's members of Full Ways and Means that maybe don't necessarily see the value in it. So I think as much as you can show that, the better chance of success we would have.
I think besides the initial return on investment evaluation or analysis, I think the way the program is structured or proposed would give us the ability to better evaluate it going forward compared to what we have today. So I think there's also the benefit of, if we went the route of going for an RFP for a wellness program vendor, some of the specific requirements or work required as part of that contract should be being able to evaluate the program, make actionable recommendations to decision makers to improve, you know, engagement and outcomes.
And if I could add that while return on investment, I think, is a very important component, and every organization decides how important that is in the overall picture. I made reference to value on investment earlier on as well. And there's some, we believe, and this is the way we talk with organizations, and many fewer organizations are talking about focus on purely financial return on investment these days. They've moved to looking at this broader view of value on investment. And that means that deeper employee engagement, addressing health equity and diversity, equity, inclusion. Are more people feeling more engaged with their work at the workplace and feeling better about being with the state? Are we connecting more people with providers that are meeting their needs? Are people taking steps toward improving their health? Does that mean that there's less disability cost? Are we seeing people move from average performers to higher performers the more their well-being increases? So there are some other metrics that we put in broader dashboards that view this overall value on investment. And I'm not trying to take away from your comment about the importance of convincing skeptics that there's a financial return on investment as well. But frankly, I think that's just the tip of the iceberg. I think it's just a part of the total value proposition.
All right. Any other questions or comments? Okay, so before I ask the board to take action or provide some very specific feedback, I thought I'd recap some of PMAC's most recent board and management directed work and ask for thoughts and additional guidance on maybe some of the short-term work or priorities PMAC should be picking up. So as you know, PMAC has played a major role in developing and reviewing the various health equity processes and tools, and helping to ensure recommendations are examined through the health equity lens. I mentioned earlier on today that PMAC has adopted the health equity tool as kind of its analysis tool. So recommendations and proposals from PMAC to the board in the future will be run through this tool. It'll be just part of our usual analysis that we do. In addition, PMAC has started working more closely with a number of key stakeholders this year, including Uplift Oregon and the Worksite Wellness Coordinating Council. We look forward to continuing to build on these relationships, and again, look forward to any feedback that the board has regarding how we can move those relationships forward in the short term. Next slide. This slide describes some of the health equity work the committee has accomplished so far. So again, PMAC has reiterated the importance of recruiting members who have either worked in the health equity arena or who have diverse backgrounds and personal experiences. PMAC has also reviewed the proposed process for the newly established Health Equity Work Group, and as I had mentioned, reviewed and approved the proposed health equity screening tool. It's also important to note that while PMAC will utilize the health equity screening tool for all major policy and recommendations that come from it, I think that this will probably be the case for recommendations that originate with the health equity work group as well. So I think that health equity screening tool is a little more globally used than just PMAC. So I will stop there. That brings me to board action item number 1, which is really just a question to you all, which is how else can or should PMAC and the Worksite Wellness Coordinating Council support health equity? Do you have any specific ideas or recommendations? Are you looking for maybe some sort of update or report first? Any thoughts from the board?
Brian, this is Ollie. Just to jump in quickly. So are you thinking like periodic updates, for maybe ongoing guidance, every quarter or monthly or?
Yeah, I mean,
Yeah,
taking it from the top, let me just share the general feedback items before we get to the HEM recommendation that I was going to ask is, how else can or should PMAC support health equity? Are there other stakeholders PMAC should actively be working with? And does the board have any thoughts on how PMAC and the Worksite Wellness Coordinating Council can work together and coordinate going forward? And again, part of the reason I'm asking these is because PMAC has been working on the HEM recommendation for over a couple years now, gathering information, coming up with a potential program design. And now the committee needs a little more feedback on what its priorities are going to be the next year and change.
Hey, Brian, this is Siobhan. So there's just a couple things that are coming up for me. I mean, I would imagine that if we vote and want the work to move forward around RFP process, that the PMAC committee would be engaged in any reviews, determining what are the different questions that we should be asking the different vendors, and I just want to say I really do appreciate all the work the committee has done. And I know you recognized that earlier, but this is a lot of information that you're bringing to us and is super helpful in terms of thinking about next steps. And so one thing that just comes up for me, I know we've talked about employee resource groups at the state. And are there any places to get more feedback or to get any feedback from the ERGs as assuming we move forward with changes to the HEM? And is that something that the PMAC committee could look at?
Okay. And is that something, do you want PMAC to do in partnership with the coordinating council?
I think wherever the synergy can happen makes sense. And I don't know whether the coordinating council has gotten that feedback loop moving or not. And
Okay.
you probably know, you and Teresa, right?
Yeah, and that's probably a good question is maybe the board, do you feel like maybe rather than trying to pull some feedback from you guys today on how Teresa and I can coordinate some of our committee work, do you want us to come up with a plan? I know Teresa's been working with Mercer for a framework for the Worksite Wellness Coordinating Council. And one of the things her and I are trying to figure out is, since there are some overlap between our two committees, is how can we do a better job at defining roles and how we then coordinate the work and work together. And so if the board's interested, I think what Teresa and I can do is work together to develop some sort of report out to you guys at a future board meeting that summarizes where the committees are at and maybe how we propose to work together going forward. Including maybe different spheres of work that the coordinating council would primarily own versus things that PMAC would primarily own. And then maybe come back to you with some more targeted questions or ideas for work priorities. going into 2022. Does that make sense?
I think that's a good idea. Do you need us to make a motion for that, or is that just something you want?
I don't feel like we need a motion in that. If we're just going to be coming back with a recommendation at a later time, I don't feel we need a motion to direct us to do that. I think the motion will happen when we bring a recommendation to you at the next meeting. And I think what we can do is work with board leadership, Kimberly, you and Sean, to work out the details over the next couple months.
I hate to ask this question, but how often does the health equity work group meet? I don't know that answer.
The health equity work group, we're tentatively scheduled to start out meeting quarterly as we get it off the ground. I think, Teresa, please correct me, jump in if I'm wrong. I think the Worksite Wellness Coordinating Council is tentatively scheduled to meet every other month.
Yes, that's right. They meet every other month.
And then PMAC meets, they're scheduled to meet monthly, but it's usually 8 to 10 times per year. So I think it feels like maybe Teresa and I can try to bring all that work together at a high level and propose how it fits together and what the impact is for PMAC and the Coordinating Council's role for you guys to react to. Does that make sense?
I like that.
Okay.
I think that all makes a lot of sense. And one more thing to just kind of put in the queue while you're thinking about the different roles, the different committees, how they work together. So, one of the topics that was part of this discussion today, is about champions, and that being a big part of the best practices. That's not directly related to the RFP, but is still part of the mix. And no question that some of the champions need to be like leadership of the organizations, the agencies, and what have you. So to demonstrate through the management structure, like this is valued, and when people take care of themselves, that's not a loss of productivity. That is an agency value. So that's important. And not all of the champions can be the same champion for not all the champions can be white men and women, right? So we have to have diverse champions as well, because people see themselves in for different reasons. And so that's another like tough one for somehow the resource groups, PMAC, the equity committee, the council, like somehow that has to be owned and consistently represented and pursued, because it's not going to fall in our lap. We will always fail at that unless we make ourselves very deliberate that we won't let that go. So I'm asking you, when considering all of the different committees and charges, that be one of the elements that lands somewhere specifically as a thing that is charged to one of the groups.
And it goes to, I think, the need to better establish and support that healthy work environment and culture. And I think that's something definitely Teresa and I can work with Mercer on to figure out how this all fits together. Because I think the Worksite Wellness Coordinating Council very much is created in that spirit. And that I think that if Teresa and I put our heads together, we may be able to come back to you guys with maybe some better information about how the committees fit together and different roles they could play that are unique to them.
Let me just give you a really specific example of what I mean. During the pandemic, there was a basic attempt in one of the agencies to establish some work site policies to encourage wellness culture related to food. And it failed miserably because it was seen as culturally insensitive. And so that is just like you just can't proceed with wellness activities without an equity lens. It will fail. So it is mission critical that people feel heard. They can, that they have honest representation, that they're part of the discussion, and don't feel like something is done to them. So I'm just, that's a specific example. It's like not theoretical. Like this really won't work unless it's equitable and it's known.
So ideally, it would be nice if future state, when Teresa or I or any staff are making some sort of general wellness program recommendations to you guys for consideration, that we almost have a checklist or some sort of higher level document that kind of explains how the council, health equity work group, and PMAC, which pieces they took on, how they coordinated, and how all that rolled up into the recommendation before it even came to the board. So does it feel like that is part of what the board would be interested in hearing too, is how maybe Teresa and I can ensure that those sorts of boxes are checked and that we go through those processes when recommendations are made to you guys, and that's part of our normal, operations, so to speak.
So I wanted to chime in and also piggyback on Sean. I think what you're saying, Brian, would be helpful. I also just wanted to, I know I brought up earlier around if there's need for additional FTEs to support wellness infrastructure to do the coordinating work, so we are hearing a diversity of voices, so that what gets implemented is something that speaks to people in agencies. And I do think that I would look to you, Teresa, the groups you're working with, to make the recommendations if they wanted the board's support to say this is needed, as opposed to the board itself saying, oh, we need more budget authority because we don't have enough wellness infrastructure support in some of the agencies.
That's a really good point, Siobhan. And it harkens back to the action that the board took almost a year ago now to approve PMAC's recommendation that larger agencies do have a full-time FTE devoted to wellness. And so I've been working with Kate on the board to develop a survey. She wanted to get a better sense of what was the current status in agencies in terms of budget, in terms of pieces of FTE that agencies might be using and could cobble together to create that one FTE position that sits in a certain place and is responsible for wellness. So that survey is just about ready to go out. We're going to get more information from that so that we can move forward with the board's recommendation.
Thanks, Teresa.
Okay. So it sounds like for the coordination piece for PMAC and the coordinating council, you guys are comfortable with Teresa and I putting our heads together and coming back at a later time with a proposal on how all of the work can fit together within the health equity lens, because again, that is a priority. And it sounds like you guys aren't too concerned with how we divvy up those roles, but just to come back to you guys with kind of an approach for how it could work for everyone and how we can make sure we're covering all our bases. And then maybe after that discussion, we can talk about specific work priorities for those two committees if we need to. So does that make sense?
Yes.
Perfect. Okay, so I do think we need to move to the next slide. We do need to ask for action. Let's see, one more slide, I believe. Okay, yeah, so this is going to be kind of the heart of the HEM discussion. So first of all, I think the high-level question is, does the board support this high-level vision for HEM that PMAC painted?
So I'll jump in here. I support it. I really appreciate the work from the committee and consultants and staff that went into this. This was a lot of work, I can see. and really exceeds what I was hoping to get out of it. Pulling together all of the evidence, comparing it to where we are now, and setting a path and vision for what this could look like, to where we're one of the higher performers around wellness, feels right to me. I also I agree with the suggestion that the committee has made around option 3. And I see the wisdom of having a vendor do this. You know, I have like an initial opinion about which would be better as far as like a standalone RFP versus a wrapping together, but I'm open to more discussion on that. But regardless, it feels like heading in this direction with an RFP, starting the discussion about what that means, costs and budgeting, etc., feels really worthwhile. And I am excited and hopeful that we can head in this direction.
Okay, other thoughts, comments?
If I can chime in for a sec, I also support it. It seems like we're going in the right direction. Down the road, we need to get some more specifics, because one of the things I worry in general about is, though that we know that getting people to make even very modest changes can have significant benefits, but I would hope that we can do this in a way that doesn't make it seem like it's a lot of work, because, I know a lot of people that just like, they can't afford to spend more than 10 minutes on this, in very long. So maybe repeated increments, but little tiny steps, so that it doesn't seem too onerous for our members. And I have to apologize because I have to hop off to go to a different meeting. But yeah, this all sounds quite promising. Thank you for.
Thank you. So does the board feel like it's, is it appropriate to take board action to vote on just endorsing or supporting a general program? Because it feels like that would be, if not formal action, just some sort of statement that, we support this vision, and then we can talk a little bit about what that means for next steps for PMAC. Any thoughts, Sean or Kimberly? I don't know if we typically would have a motion just to support something or endorse something, but since we're not making a overly specific program recommendation, I thought that may be something we could entertain.
So I feel like you've heard several talk of their support. I guess maybe I'd want to know if there's anybody that doesn't support really us moving forward and looking at this. Maybe that's a better question. I don't know. Unless, Ali, you think we need a formal motion and I need to take a vote.
No, I don't think so. In fact, Mark Perlman just jumped off, so I think, yeah. So.
Oh, are we down to less than a quorum?
Yeah.
And I'm very supportive too. Just want to weigh in.
And honestly, that's okay. We can always, if we need to tie up loose ends, we can come back and just ask for a formal decision at a later time. I think the important thing is to make sure that this vision that they painted is consistent with what you all want to see as decision makers. And if it is, then I would be interested in spending a few minutes talking about, are there things that you want PMAC focusing in on the short term related to HEM? Is it worthwhile to come up with recommended health actions, as long as those actions are ones that aren't audited or verified? Are there other bodies of work even related to health equity that you're interested in PMAC picking up sooner or later? Or is the next step for you to see how Teresa and I propose to move kind of the committee work together holistically, and what that means for the things we'll ask you guys to review and decide?
So I guess I would ask you, Brian, so the work that you've done with PMAC, do you feel like they have kind of a little group of health actions that could be added easily enough? Or do you feel like that would take a lot of PMAC work that we should probably do towards combining the committees and getting more bang for our buck? I don't know.
Oh, I think there's bandwidth. We've done this in years past. Again, under our current HEM program, since it's really on the honor system, what we've done is just highlighted actions for members to consider. And so I think that is completely something that they can do and have the capacity to do. And I also think it's something that Teresa and I could discuss and coordinate, because there may be, if we're trying to get our kind of arms around how we address the overall workplace culture, there may be things that Teresa and her group may want to recommend for health actions. And so, maybe her and I can put our heads together and see what we can come back with.
Brian?
Go ahead.
Oh, go ahead. Sorry, Kimberly.
Siobhan, you and I have already talked about it. I just feel like we need something. I think we've got all this COVID, whatever you want to label it, and I just think we need to help our people just a little bit. I don't feel like we should delay. HEM is HEM, and maybe they've done nothing other than sign up, and they'll get to it later. But I think if we can help our peeps, we need to, just because I see that, especially in corrections, I just think that COVID has done a number on the well-being of, I don't know how many people are members of PEBB from corrections, but it's well over probably 4,000 people or something. I don't know. And with their dependents, maybe we'll get as high as 12. I don't know. Anyway, I could be making all that up, but you know what I'm saying? I just think we need to keep moving towards something to help them.
And is it fair to say that if Teresa and I keep in mind the pandemic situation and the health equity lens, that what we bring back to you is more likely kind of to meet what you're looking for?
I think so.
Okay.
And I just wanted to weigh in too that I think it's probably useful to look, I don't know if it's the HEDIS numbers, but looking at where our members are getting their preventative care, because that could help guide, a focus on these are things that people need to be paying attention to, that because we know that care has fallen off during the pandemic too, and getting people to do the regular preventive care they should be doing may need some, additional reminders around it.
Perfect.
Hey, yeah, Brian, this is Nadine. Can you hear me?
Yep.
I just really want to echo what I'm hearing too, because I've had a lot of thoughts of this. A lot of people aren't going to their provider, which is actually really scary because we know stress has gone up. So I think there's like a pre-messaging too that we can remind people. You can do a wellness check at home. You can do that through telehealth. You can get your children, mental health check, all of that. So there are services. We need to remind people that they can utilize these from home and still stay safe.
Okay, and I'm seeing board members nod. So I think this is giving us some good direction on next steps, the things we can focus on.
The other thing I would add around, the big project of an RFP, as you pointed out in the presentation, that RFP would be competing inside of our own organization for resources. So, having said that, there is a certain amount of there's an art to timing when it comes to RFPs and legislative concepts, right? So it is normal that Oregon goes through cycles of budget budget booms and budget busts. I mean, that's a little dramatic, but that's normal. Like, we just count on it. So that's just the way our economy and also our state budgeting works. So we are currently, amazingly, in a window time frame right this minute of not being in a recession, or at least in a state budget collapse. So seeking permission to, invest in something is better to ask when you're not in the middle of a recession, which is not, or a budget crisis, which is not the time to ask for permission to do such things. So, knowing that in the 20th century, about 1 out of every 3 years was a recession, you kind of have a window. Not that it's you can count on it every 3 years, but it's like it's an average. So you can't just wait. What I'm saying is you can't just wait until it's convenient to be like, let's do it this year. I mean, some of it's you kind of have to strike while the iron's hot kind of thing. So so I'm just floating that. I know we have a lot of RFP plans, and they are all mission critical. So we don't need to sort that out right this minute, but perhaps there is some discussion with Ali and the rest of PEB team. I'm happy to participate if that's useful. I'm sure Kimberly. And maybe this has something to do with the PMAC committee as well, or maybe it's more of an administrative discussion. I don't know. But I'm just throwing it out there that we are talking about these 3-year time horizons. That's once you have an RFP, right? The RFP has its own time horizon, right? Which is probably multi-year, maybe. So I think we really need to start thinking. I feel that this is promising enough that it should be. I would advocate that this be considered as part of our planning for RFPs and like where that fits as appropriate, at least in planning.
Yeah.
And I'm sure, I mean, of course, at some point we're actually going to have to make a formal vote on that kind of thing.
Yep.
But maybe it would be the thing to get to in order to actually vote on something would be like, this is where we think it would fit, and this is what it would take, that kind of thing.
And I would, to that end, Sean, I would say, I mean, you hit the nail on the head when you mentioned, an RFP like this. It's a long-term project, and both executing the RFP once it's developed, but also just planning and figuring out, how it relates to other work and other priorities. I would say that we probably want to hold off on having a lot of those discussions until early 2022, in light of the fact that we have a consultant RFP out on the street right now. And both OEB and PEB look to our consultants to provide a lot of that strategic advice. And so what I would envision is, once we get through that selection process, we probably have 2 of the first orders of business would be just talking about our renewal process that drives our year in and year out operations, and also our procurement processes. What does the consultant think are the most important services or benefits to go out to market first? And a medical RFP and a wellness vendor RFP would definitely be part of that discussion.
Mm-hmm. Yep, that makes sense. In which case,
oh, sorry.
This is Nadine again too. Oh, I'm sorry, Sean. I thought you were done.
Go ahead. Everybody go ahead.
I'm hearing a couple of conversations that I want to loop together right here. And one is how difficult the pandemic has been for everyone. We need proper wellness plans in place for retention, for mental health issues. And then the other conversation, to pull this in is, what's that financial benefit? Beyond the financial benefit, right, is an engaged workforce that's resilient, which then touches on your retention, right? Not losing staff, having staff out all the time. When we have a chaotic situation like this and we're staying healthy, we're engaged, and we can produce more. So I just kind of want to connect all of that together.
Yeah, that's very well said. And I would just echo what Sean and actually what Kate said earlier, that, the budget process will really be starting in 2022 for the 23-25 biennium. So really refining that value proposition and the return on investment would be, at least getting a placeholder policy package together, as a potential RFP progresses and you get more details, you can obviously amend it, but getting something together early on, I think, will help.
Yeah, so totally agreement there. So thus, to the question at hand, for the PMAC committee, it's knowing that there is a timeline that is less than immediate, let's say, to implementing a lot of these exciting ideas. And knowing that, frankly, I mean, various people have said this in their own way in the past few minutes, given the sort of crisis that a lot of people are in. What shorter term changes or additions or whatever might there be? Might be something like, as you say here on the slide, like modifying the HIM program, the short term, like what would make the most sense for the most impact given where people are? I mean, because it is going to be a little while before.
Well, and Sean, maybe that's the direction from the board. Maybe that's the question for Teresa and I to work with the committees, and for that to be the focus on the shorter term work, knowing we have this consultant RFP out there.
Right.
In light of the pandemic and our members' struggles, maybe asking PMAC and the coordinating council not only how its roles could be developed and how they could work together, but what they think the priority should be in terms of maybe recommendations, whether it's health actions or maybe there's program gaps. If we can identify program gaps that we could operationally fill quickly, that wouldn't require a 18-month RFP, I think that would be right in their purview to brainstorm and to try to come back to the board again, maybe at the beginning of 2022 with a more developed plan and some more developed, I think, ideas for you guys to react to really get the shorter term work underway and moving.
I like that.
And it sounds based on Nadine. Nadine's a member of the committee. And correct me if I'm wrong, Nadine, it seems like the direction was pretty good in terms of what the board's interested in. I feel like this is something we can take back to the committees and start getting our arms around and having some productive discussions.
Yeah, and I also just want to assure everyone we are prepared with, these short-term steps and would like to begin implementing those while we have the first year going. So it's not we're pushing people straight into this, but we also have the support system in the workplace. The managers understand what it means to keep workers healthy, have healthy meetings, making sure people have breaks during long meetings. So we have kind of that focus going on, dropping down to the floor, but then also, the slow launch of this system. So we really want to see this really nice, I call it synergy. I know that word's been used too much, but even from Uplift Oregon, right? They're now connecting with people, letting them know about their benefits, their EAP benefits. So it's really approaching it from all these different places and a whole. That's how we get the culture shift. It's not going to be just with our HIM program. It's all of it together and us constantly working together.
Thank you.
Well said.
All right. So any other thoughts for the good of the order? Sean and Kimberly, I feel like, again, you guys have provided great feedback. It's pretty clear that the board endorses this future vision of HEM, and that really sounds like you guys are interested in Teresa and I working with our committees and maybe coming back with a plan and some proposals for you guys to react to.
Absolutely. And we would be regress to not thank PMAC and Stephen and Brian and the Wellness Council, Teresa, you guys. The work of all these groups just helps feed into really PEBB keeping us on track with those goals that we've set, and really how we're trying to remember how important just all the different areas that we're working on, it just helps to have these other groups kind of keep us on track and come back to us with suggestions. It really does help us, I think.
But I appreciate it, Kimberly. I mean, PMAC's a terrific group of people, and honestly, just looking at the information, I'm kind of blown away because, again, we're not all healthcare experts. You know, between that and Stephen's leadership throughout this process, I've been really impressed. It's a very thoughtful and collaborative group, and they serve the board well.
Thank you. All right, I need to feed into updates from Innovation Work Group. Sean, and I'm not sure which of you is going to speak. Is it going to be Sean or is it going to be Margaret? Hi, Margaret.
Hi, good morning. I'm Sean. I can get started or you can. Let me know what you prefer.
Go ahead. I was like, I have a guess who's going to go first.
Great. I'm happy to do that. And I think these updates can be pretty brief. I'll kind of run through just a quick 3-minute overview and then certainly invite any comments or questions from the board. But in terms of what the Innovation Work Group is up to, there are a couple of major topics that are on the work group's docket for the next couple of months. First off is the Centers of Excellence program, and that is a program that we've been working on an ongoing basis. Starting with today's meeting, the work group is going to be reviewing preliminary proposals received from carriers, having some discussion around those, and ultimately with the goal of having some recommendations to make to both the PEBB and OEB boards by midwinter. So for the next couple of meetings, I anticipate that a lot of the work, the discussion in the IW meetings is going to be dedicated to the COE program. And so certainly, and I think an email was sent out to board members alerting you to that update. You're certainly invited to attend those Innovation Work Group meetings and be part of or listen into that discussion as your schedules permit. Another topic that the work group has on their agenda for next month is to review year 1 audit findings of the hospital payment cap. That specifically is related to a financial audit of the cap to ensure that aggregate payments to individual hospitals stayed within that 200% of Medicare upper limit. So that audit work is ongoing, and we anticipate that next month the work group will review the findings related to that. The third major topic that the work group currently has in process that will be ongoing for, I anticipate, the next several months, perhaps beyond, is related to behavioral health. It started with an initial gap analysis the work group looked at around network adequacy for carriers' behavioral health networks. And from there, the work is evolving. We are going to be looking at in December at some preliminary options for contract reporting requirements and standards that PEBB and OEB might consider for their contracts. I don't anticipate that there will be any decisions made at that December discussion meeting. That discussion will really more be at the preliminary phase, and I anticipate that moving forward into the winter, that discussion will continue over the coming months and evolve. We are doing that work in coordination with some other work going on in the state around behavioral health, particularly with some new reporting that's being implemented by DCBS under House Bill 3046. And we're also going to be working in conjunction with the Behavioral Health Metrics Committee, which is just getting its start within OHA. So we are eagerly awaiting to see how that committee evolves and how we can be a stakeholder in their work. So those are sort of the main topics on the Innovation Work Group's plan for the near term. One additional topic that's out there that I anticipate is looking more like late winter, early spring, is around value-based payments. Coming back to do a sort of a status check on where PEBB and OEB currently stand with value-based payments, looking at progress our carriers have made on expansion of VBP and what sorts of challenges they're facing. And then also looking at sort of the broader statewide initiatives around the status of the cost growth target program and the value-based payments committee that evolved from the VBP compact, to which PEBB and OEB are both signatories. So those, in a nutshell, are the major topics the work group is working through in the coming months. I think the work plan is certainly going to evolve as we get into 2022, and I expect that we will be coming back to the board with further status update in the early part of 2022, and to get more board input and thoughts around the longer term 2022 work plan. And Sean, certainly if you have any thoughts to add to that, please chime in. Likewise, anyone who has questions, I'm happy to take those.
Good overview. Thank you.
Of course, you're very welcome.
She just nails it, right? She just gets them. She just gets it. Thank you.
Well, thank you.
So I don't have anything down about public comment, but can't people comment even though we didn't cover? I mean, we had a presentation today. We could have still had somebody do public comment, right, Rose?
Sure, they can, but I don't have anybody unless somebody wants to speak up on the phone.
Ali, did you have anything for us?
Nope, that's it. Great meeting. Thanks to PMAC Worksite Wellness, Mercer, everybody as well. That was just great work. Yes. Great discussion.
And I hope everybody has a safe Thanksgiving, whatever that looks like in your life. And I hope that those that want boosters are able to find them and get them. And everybody continue to be safe. And gosh, we'll see each other again in December. Wow. This year went fast. Not fast enough due to COVID, but it went fast. All right.
Thank you.
Thank you.
Bye-bye.
Great to see you, Greg.